Thank you. It's a real honor to be here, and I am incredibly grateful for the invitation. So thanks to the organizing committee and to the members of the Congress. This is a real opportunity, and I hope an opportunity for a little bit of dialogue as we talk today. So I'm going to talk about thinking about the use of implementation science in critical care, and in particular, thinking about complex interventions in complex settings. First thing I'm going to do is just sort of level set, thinking about how is implementation science already being used, what are the kinds of things that people are thinking about, and then a very, very brief overview of implementation science as a field. And then I would like to spend the rest of the time thinking kind of to the future and thinking about the things we could be doing in implementation science and critical care. So in terms of level setting, let me just say that implementation research and practice has been going on in critical care settings for at least a decade, probably longer. All of you know that critical care is one of the spaces where a huge amount of research is being done. Evidence is being generated literally every day, and that new evidence needs to be taken up in practice. There have been several literature reviews of implementation science used in critical care settings, and a variety of clinical topics have been the objects of implementation research and also implementation practice. Central line catheter-associated bloodstream infections, or CLABSI, were among the early things that were the focus of implementation. Thinking back now to the early work done in the state of Michigan, for example, and other places. There are a lot of bundles in critical care. It's been one of the things that's puzzled me for a while is why so many bundles? But I think the complexity of the care and the fact that there are so many different things that have to be attended to pushes the idea that you have to have complex interventions, and bundles are one type of complex intervention. So bundles around ventilator-associated pneumonia, ventilator-associated events, the ABCDEF bundle, which many people are familiar with in terms of liberation from ventilation, and nutritional support has been another area of research and focus. And then finally, mechanical ventilation, which is, of course, quite central to critical care, but not the entirety of it. Clinicians in critical care do a lot more than mechanically ventilate people. And so there's a lot more to think about, and that's one of the things I would say is a challenge and a matter for some additional focus as we move forward in thinking about how implementation science can be applied and used in critical care settings. So let me start off talking about implementation and implementation science with a few definitions. I have a slightly more streamlined definition of implementation science than many people do, because I like to start, I think it's critical that we start with thinking about what is implementation. And I think it's important to say none of us discovered implementation or invented it. The notion of implementation has been around in human behavior and human activity for millennia. That anytime you take on new activities, you're implementing those activities into the work that you do. So a simple definition of implementation is that it is a process of planned human behavior change under organizational constraints. And let me say that that is an additional piece. Lots of people talk about implementation and behavior change, and I think it's fair to say always about humans. But the notion that this is under organizational constraints is a really important component, because as we talk about it, especially in healthcare, but not just in healthcare, we're talking about the work of people who work inside organizations, who are not independent decision makers about everything that they do. Yes, as professionals, many of us have a good deal of autonomy in our decision making about clinical practice, but it's not a completely open field. We make decisions that are bounded by the organizations we work in. And let me also say that the term constraints is not necessarily a negative term. It's also a positive thing in that the organizations that we work in can facilitate our work as well as imposing constraints on us. So if that's the definition of implementation, we think about it as a process, a planned process of behavior change inside the constraints of organizations. The science of implementation is, quite honestly, just simply studying that and learning more about how it works and how to influence implementation. But I'd also like to say that there's a further piece of this that we don't usually, a term that we don't use very often, and that is implementation practice. And I would argue that that's possibly more important than doing the science of implementation, that we actually begin to practice it using the tools and methods that we've developed from the research that we conduct. Otherwise, we're doing research into a vacuum. If the work we're doing isn't taken up, if we aren't implementing what we learn through implementation science, then we're losing a lot of resource and opportunity. And hopefully, if we can use those tools and methods, we can improve efficiency and effectiveness of implementation work. The diagram that's on the lower right-hand side of the picture that you're looking at is really just my schematic of what the processes of implementation involve. They involve starting with a problem or a gap, using process models, of which we have many in implementation science that have been developed through many, many different empirical studies, to assess and understand the nature of the gap, the nature of the solutions to the gap or the evidence-based practices that we are trying to implement, and then understanding the context in which we're doing implementation. So those are three major things that require study for the most part. Very few of us can simply say, I know all there is to know about the gap itself, about the solution to the gap, and then about the context in which the work needs to be done. As I said right at the beginning, critical care is by its nature a complex setting. It involves a lot of moving parts, a lot of people, a lot of different ways of acting and behaving and doing work. So those are all things we need to consider. What implementation science has brought to, hopefully, the practice of implementation and to improving the quality of care over time is systematic discovery and finding out about those contexts, the gap, and the solutions, and putting them together to figure out the strategies that hopefully will effectively and efficiently help us move evidence-based practice into routine practice. So that's a big piece of where the science sits right now, is understanding strategies, testing new strategies, understanding how strategies work in different contexts and different settings, and then evaluating whether they actually succeed in speeding up and making more efficient and effective implementation processes. And then there's finally a need to evaluate all of these, and there's been quite a bit of innovation and scientific development there, which I won't be talking about today, but I would urge those of you who are interested to learn more about and to think about. So that is, frankly, in a nutshell, all I'm going to say about what is implementation science itself. And now I'm going to ask you to use that very brief nutshell and your own knowledge of implementation science, because I know for a fact I'm looking at least a few people who have done implementation research in critical care and who have good knowledge about it to begin with, to start to think about where can we go with this when we think about critical care and the complexities that are embodied there. So first, I think it's worth pausing for a second and just saying, well, how is critical care different from any other kind of care? And there are lots of good answers to that. For one thing, it's highly organizationally embedded. It's true that you can have critical care in mobile units that get deployed in, for example, conflict settings or to disasters, and deliver critical care services to people not inside bricks and mortar. But to do that in and of itself is a huge logistic enterprise and actually makes visible how complex these settings are and how complicated it is to appreciate and understand and effectively use all of the machinery and equipment and other things that people need to use in order to deliver care effectively. So I'm going to start on a few of the things that, to me, make the most difference in terms of critical care versus even acute care settings, much less primary care, long-term care, or community-based care. One is data. And I think it's really important to think about data. Those of you who work in critical care settings know that data is everywhere. You're getting data pretty continuously, most of the time from most patients. And that's really different from almost any other healthcare setting. I guess I should mention at this point, I'm going to be talking about health from here on. Implementation science actually affects and is used in education, social services, industry, many other settings, but health has some very unique aspects. And so those of us who work in healthcare-related implementation science are sort of specialized in health in a lot of ways. So back to data and thinking about critical care and how it's different. When I think about data in a primary care setting, I think about plops of lava out of a volcano. It seldom erupts, but when it does, you get a big plop of stuff. Volcanoes that can be deadly, in this case, hopefully it's useful, but you get this flow of data and then nothing. And that's what primary care is for most of us who are healthy. When we go to see our primary care physician once a year, maybe a couple times a year, that's when they get data from us. The rest of the time, there's no data. We're out there living our lives and doing our thing, and unless we're connected through smartwatches or various sensor kinds of things and really take it seriously, the data don't exist. But those data, the sensor data, doesn't get to our clinicians anyway, so it's sort of irrelevant in terms of healthcare. So one issue is how much data and how often. In critical care, you have highly granular data about individuals coming in a largely continuous stream. I'm going to say largely continuous because each data point has its own characteristics, but compared to any other setting, even acute care settings, for the most part, you have much more data more of the time. But the volume can be overwhelming. The tools to actually use and interpret the data aren't all that readily available, and we're not using it much of the time. And a lot of it's not needed except in the moment when you're actually delivering care. It won't necessarily make sense, even 5 days later or a month later. So that's a really important difference between critical care and all other healthcare settings, I would argue, that instead of sparse health data, you have dense data, but the density may not always be where you most need the data to be. And an example of that is that you may have lots and lots of data about someone's central blood pressure, but you don't necessarily know how they're feeling at any given point in time, because those data can't be easily monitored through equipment and put up on a screen. So moving on from data, and these things are all overlapping and interrelated, so let me just say that these are not distinct and separate and mutually exclusive. Acuity is in many ways the definition of critical care. It's what makes care critical, that somebody is acutely ill and unstable and needs both stabilization and acute treatment. So this raises a whole set of issues. Again, this is thinking about potential scientific study and research that we can be doing in the context of critical care and implementation. Issues around adequacy of staffing. And when we talk about staffing in today's world, we're not just talking about the physical individuals, the humans who are in person in a unit. We're talking about what's available through telehealth. And we're talking about what's available through other forms of consultation, rapid or slow. We're also dealing with unstable and rapidly changing patient status, which in and of itself produces complexity and a lack of immediacy and often a focus of attention that requires that you can't necessarily think about all the things going on around you if you have to think about the care for this patient in this moment. Issues around deterioration and improvement, the literature in that area is large, but we still are sort of in our infancy of figuring it out. We don't really understand why people deteriorate, when they do, how they do, and how best to treat deterioration. And in a couple of minutes, I'm going to talk about boundaries, but this is a critical area of boundaries between a person who's being cared for in one setting and the need to increase the level and intensity of the care that they're receiving. And then the last thing I would say about the broad topic of acuity is that it's a highly charged environment. Because we're dealing with critical illness, the people around the person who's receiving care are often very stressed, very anxious, and this creates another whole level of things you have to think about, work with, and deal with. So this is a topic that's near and dear to my heart and many of our hearts, I think. The notion of teams and what teamwork means in a critical care environment. Teams are essential throughout healthcare. There's very little we do in healthcare that doesn't require a team somewhere, at least in the background, if not right present as care is being delivered. But in many other settings, those teams can be pretty backstage, like in the lab or off doing paperwork while a single provider is interacting directly with a patient or family. In critical care, the team has to be there and it has to be functioning together in order to coordinate care and make sure that the care is delivered as it has to be delivered. So teams are absolutely inherent and they're central. But I will argue that we don't understand teams in healthcare very well at all. And some of that is the way we work, that people get scheduled not on the basis of what team they belong to. And you'll find that that's not true in the military, where a lot of the team research that's been done has been done in military and it's been done in aviation. And those are both places where people actually consider the team as they do scheduling. But in healthcare, we typically don't. We simply say, okay, your schedule is X. What X means is you'll be working with this group of people during your day, your shift, your week, whatever that is. And you're seldom choosing those people. Sometimes you might be able to, but most of the time you can't. This means that there's this shifting aspect to teamwork, and stable relationships are hard to create, they're hard to maintain, and over time, a unit can definitely develop a cohesiveness and coherence across the unit, but it doesn't mean that every team within that unit is coherent and cohesive. There's a lot that we need to think about. And a lot of the work that's been done in teams in settings other than critical care doesn't have the urgency around teamwork that critical care does. So I would argue there's a huge area of study here, and there are many people who are engaged in that study, but I think we need more, and I think we need more focus on some of these unique aspects and thinking about it a little bit differently from taking it from the military work that's been done or teams in industry and manufacturing, firefighting, and assuming that some of the things we've learned are going to hold in these other, specifically critical care settings. And then I'll just mention the notion of social networks, which is really important and is, again, a sort of an emerging piece within implementation science. Actually, social networks underlie the early stuff in implementation science, and particularly Everett Rogers' work in diffusion of innovations, which extended from the 40s through into the 70s. And there has been quite a bit of social network analysis and research done focusing on, to some extent, teamwork, but also processes of implementation and spread of innovation. But it's still in its infancy, and we still are trying to figure out how we can measure the social networks that are inherent in the teams that work together in health settings, and especially in critical care, without the intrusion and the burden of filling out massive surveys and other ways of collecting the data that we need. So I'd like to switch quickly and talk about the boundaries between different settings, because critical care is not an island, and doesn't exist in a vacuum. It is a continuous flow between acute care for sure, but also direct from the community, direct from the emergency department. The whole emergency medical system is intricately related to critical care settings. So we have all of these boundaries, which are frankly pretty unexplored. And we've got protocols and ways of dealing with them, and I would argue mostly just ways we deal with them that haven't necessarily been thought through very well. But there's a huge scope for research in this area, and some of that work is being done. Work on handoffs, rapid response teams, triage issues around rationing of care, which was a big topic during COVID when we didn't have enough ventilators in a lot of settings to be able to offer a ventilator to everybody who might need one. And then the notion of just bed pressure. What do you do when there is no bed available in the setting that a patient needs to receive care in? These are all things that I would argue require a lot more attention and thought as we think about both innovation and new interventions for improving quality of care, but also implementing things that we do have some information about already. So, thinking about how to move forward. Increasing numbers of people who are critical care clinicians have been trained, have trained themselves, have learned about implementation science, and I would say, and implementation practice. And the boundary between the science and the practice isn't at all clear. It's very, very fuzzy and very gray. So there's a question of how can those folks be deployed? Is there a way that people could come together, perhaps, in some kind of loose collaboration? And frankly, in science, loose collaborations are better than tight ones. To think about how to work together to answer some of these questions and begin to address some of these topics in ways that will allow us to move our evidence forward and move the science forward. So new evidence is being generated all the time, as I said. New treatments are very important. We know that we don't know enough about how to treat people who are critically ill. But that's not the only evidence that we need. And in fact, at this point, if you really stop to think about it, we have probably a backlog of things that should be implemented that would actually make care better, improve outcomes, improve quality of life, both for providers and for patients, that aren't being used, in part because getting them into practice is hard. And it's especially hard to do in complex settings, as we've just been talking about. I think we need to think a lot more about behavior. We talk about practice, and we talk about workflow, and we talk about the way we do things. All of that, the pieces inside each of those words or phrases, are discrete behaviors that people are undertaking. Right now, I'm engaged in the behavior of talking. Hopefully, many of you at least are engaged in the behavior of listening and thinking. Those are different behaviors. And when you think about your work setting and the work you do when you're taking care of patients, your time to listen and your time to think are different from the actions that you're taking. And as we think about it, we need to get much more granular about our descriptions and our identification of behavior. We also need to think about behavior of many more people than we usually do. It's not just the behavior of a provider, it's also the behavior of a patient. Some patients are so sedated and their level of consciousness is so low that they aren't able to sustain or do much behavior, but many patients can and do, and how they behave matters. Certainly outside of critical care, patient behavior is critical and essential to understanding behavior change. Family members, managers, a group of people that we don't think about often enough. And then I'll just say IT staff are really important. We recognize that, but we also don't work with IT staff very effectively or probably enough. Issues of fast and slow thinking have been discussed and are thought about, but heuristics, which are a characteristic of fast thinking, are really important, and I would argue that in critical care practice, essential. It's part of why people train for years to become expert clinicians in critical care settings. But we need to stop and think about when can we use heuristics effectively and safely, and when should we not use heuristics? When should we stop and really evaluate the situation and take a moment for pause? We need to use the evidence we have. We really, we are wasting a lot of life and a lot of time, energy, and people's emotional and physical well-being as providers as well as patients by not using what we know effectively. And we need to be thinking about the high burden, high volume conditions as much as we think about those sort of things that I care about the most, maybe because they've affected me in my life in some way. But what are the things that affect people broadly, and within the settings in which you work, the more common things for which we may not have very good evidence? When we think about evidence generation and what to spend our energy and time on, we should be focusing there. And we need to think about what evidence most needs to be implemented. As an implementation researcher, I know that I have done things because I think they're important, not because society thinks they're important. But they're things that are interests or passions of mine, and all of us will do that. We need to be passionate about the things that we engage in and spend energy on. But we also need to be thinking about how to align our interests with broader interests, and in particular with the things that really do need implementation. So I'm just going to close by saying that there's a lot that's out there. This is just a tiny, tiny little piece of snapshots of some of the papers that are out there. And this is part of what makes the science of implementation so complex. We're not one science. We're actually a very synthetic field that draws from all kinds of sciences and all kinds of disciplines to form this rapidly evolving and emerging discipline. And I would urge people to take a look at, hopefully, some of the papers I'm suggesting you look at here. And I'll just say, they probably will raise more questions than answers if you do that. But I would strongly encourage you to think about doing that and to think about applying it to the important questions that I think are central to critical care and to improving the evidence base and also the implementation of that evidence base in care. So thank you again. I really appreciate this opportunity. And I hope we have time for some discussion.